Hello, I'm Chris Salisbury, and today I'm having a chat with Paul Little of Medics Voices. Paul is Professor of Primary Care Research at the University of Southampton and recognised as one of the leading primary care researchers in the world. So, Paul, thank you for joining us.
You're most welcome, Chris.
What we'd like to do, Paul, this morning is to just really understand a bit about your story. So, let's start at the beginning. How did you come to do medicine?
Yeah, well, that's a story in itself. I think it's probably sort of very early, just prior to teens, I was thinking, quite like the thought of medicine. My mum was a psychologist doing some research, and I really liked the fact that, you found satisfying results that could make a difference for folk. Then I got involved in music as a cellist, and very glad I did because I wouldn't have met my lovely wife had I not got involved in music. But you become a bit of a sort of bigger fish in a smaller pond. And much so I enjoyed playing. I was a slightly nervy performer, and you have to be pretty robust about being able to perform in music. So I couldn't see myself really being a performer. And I did academic music up until a point, and I just didn't enjoy dissecting music. So having gone for the idea I'd be doing music either as a performer or as an academic, couldn't see myself doing that, and so swapped horses after my first lot of A levels. Did physics in a year and took a year out after that. So in effect, I had extra 2 years, but applied for various medical schools, got into Oxford, and was very happy there.
Okay. Did you come from an academic family?
Well, both parents went to university. My father was in the Foreign Office. He had a sort of got a first class degree. They both met in Ireland at Trinity College Dublin. But my mum did pursue an academic career for a while, but ran into the ground at the end with her PhD, not because of, I think, of what she'd done, but because of a not particularly fair examiner who was, and we all know what that could be like. And so she just couldn't face the revamp that she needs to do. But she enjoyed her academic stuff, produced some nice papers, some of which I read. So I think
Mm,
that's partly what attracted me, I think, to
mm,
thinking about being a clinical academic, particularly.
mm.
As I'd seen it as being a satisfying thing to do, and I'd seen my mum do it and enjoy it.
So then you went to Oxford, but I think I'm right in saying you didn't initially, after medical school, start off straight into general practice. Is that right?
I knew fairly early on I wanted to have a research element of my job. And there was a research job in Brighton. I thought, well, I'll dip my toes in that, see what it's like. And I was interested in sort of larger questions about common illness. And so part of the job was running a Me Too blood pressure trial for my boss, and part of it was allowing me to do what I wanted. So I did a study on diet and hypertension. Um, but I knew nothing about research or research methods, and my boss certainly didn't. I mean, he was a rather eccentric, charismatic guy who ran the renal unit, but he wasn't a researcher really. So that was my first dip into research. I did enjoy it, but I realized I was really slightly at sea, which I was. Went back into medicine, did the medical rotation, and at that stage, I thought that I'd be aiming for public health with a clinical, if you like, a clinical and an academic component. Um, got aimed to get the medical membership and then do public health exams and things. But I realized that really did love seeing patients, and I didn't want to be in a discipline where I couldn't see patients. And so public health stopped. I hadn't been thinking of general practice. I'd been thinking of basically a hospital or public health career, and having basically got my postgraduate qualifications, ready to go on in the hospital sphere. I couldn't see any of the consultants around whose jobs I really wanted. They didn't see much of their patient. They saw them in outpatients after having seen them in the acute ward. I thought ultimately I quite enjoyed the acute medicine bit, but I didn't find the interaction with patients over the medium to longer term. Well, it just didn't happen for most of the hospital specialties. And I then rethought. So, well, why have I been ignoring general practice? I want to be doing things that are common, dealing with common problems that are important basically for public health. So it would fit in with the idea of doing something that would make a difference to lots of people rather than just for a small number of people with a particular specialty. So I then looked around and thought, what are the possibilities for academic practice? I'm a country boy basically, so I wanted to be outside London. So I looked around for departments outside London. So Southampton it was, and so I came down to Southampton, identified a practice who were just wonderful with me in terms of their flexibility. Went and had a word with John Bain, who was head of the academic department then, and said, look, I'm interested in a clinical academic career, and I'm pretty sure it's going to be general practice, but this is my plan. I'm going to start the training year in Romsey, and then I'm going to go abroad for probably a year or two, because I've always had a passion to go and do something in a low middle income country. And then I'm going to come back and finish my training and aim to pursue a clinical academic career in general practice. I went off to Nepal, had an amazing time, came back after sort of 18 months-ish, 2 years-ish. John Bain had left, and Anne-Louise Kinmont was now the new prof. So I went and explained the interaction I'd had with John, who told me to come back as soon as I was back, and said I was interested in an academic career. And Anne-Louise obviously saw something in me and said, yes, fine, we'll work together on an application. In those days, there were only two things you could apply for. One was an MRC fellowship and one was a welcome training fellowship. So I applied for a welcome training fellowship. I was lucky enough to get it, which is great. Gave you the opportunities to do MSc training. So I did an MSc at the London School. So started to develop, an understanding of research methodology, basically. So that was the key sort of turning point, I guess.
And you were the first GP to get one of those welcome doctoral fellowships. I think that's fair to say.
Yeah, I think that's right.
And then you went on to be the first person to get an MRC clinician scientist fellowship.
Yeah, that's right.
I think there are two interesting things about that story for me. One is we're about the same age. We started about the same time. I would never even have occurred to even known it was a possibility to go to something like a welcome fellowship. It's interesting that you did, and that's probably because of Anne-Louise telling you about it. And
I wouldn't have had a clue. It was Anne-Louise, looking after me and suggesting that I applied.
Let's just go back to the common illness theme, because I was going to come to that in a minute. When I first became aware of you because of all your studies on sore throat and coughs and use of antibiotics. That's been a kind of theme all through your career, hasn't it? That interest in common illnesses.
Yeah.
And yet, although these are common, there's incredibly little, prior to you coming along, there was very little good research on what to do about sore throats or coughs or whatever. Why do you think people weren't doing that research, and why did you want to do it?
So how I got interested was the study we did in Nepal, which I sort of mentioned previously, was just an opportunistic thing. So I knew that I wanted to go and do something, whether it was in the clinical context or a research project in a developing country or a middle income country. And my wife worked for an ENT surgeon who's one of these remarkable characters who'd set up a charity in Nepal to do ear camps for people with chronic suppurative ear disease, basically. So Neil, he is just a fantastic can-do character, managed to get £20,000 to support us doing a survey of deafness and ear disease in Nepal. And basically what we found was that, we were just looking at ear disease. So we found that, suppurative complications were relatively common. Deafness was relatively common. It's probably one of the biggest disabilities in developing countries. So very sort of common problem, people not getting adequate treatment. Then he came back and did my training year in general practice. And there was antibiotics being shelled out for most And my practice was pretty good practice, but antibiotics were being shelled out for most conditions. So I did a bit of hunting around and looking at what evidence there was, and there wasn't very much evidence, and what evidence there was suggested that really we weren't doing terribly much for symptoms anyway, which is what people were coming with. And so I thought, I did think then, but what is the impact of prescribing things for people in a short-lived illness where it will settle, and they might think that it's the antibiotics that is allowing it to settle? So I thought in my training year, what we need is an open trial to look at beliefs and behaviours following different prescribing strategies. But as you say, why weren't people very interested in this? I think it's because, and I came across this in some colleagues. They said, well, it's trivial, you know. It's a quick consultation. It has sort of little public health interest. So I think people were at that stage not really understanding the public health importance of antibiotic resistance. But it was out there. Actually, it was largely ignorance about what was going on, to be honest. So I've always thought it's important, not only because I think it, you know, for something that affects millions of people every year, and most of us will get some kind of respiratory infection each year. So it's of huge sort of importance for the workplace, for our consultations. But every surgery you did, you'd see people with infections, and you need to know, what should I be doing here? But to be fair, I think when, you know, we're talking about, you know, the 80s, early 90s, most of the things that we did had little research. So maybe infections weren't that much different from anything else.
Yeah, and the other thing that struck me, I looked at your CV and some of your earliest papers, and right from the very beginning, you were doing randomized controlled trials. Do you want to tell us about that?
It's not that I don't believe in observational studies, because I think they provide very useful evidence, and sometimes that evidence is more generalizable. But confounding is a key problem. You know, confounding by indication is a really important problem, and it's very difficult to get around fully. So whilst you can try and find ways of doing it in observational studies, and we have done. But ultimately, you do want to try and get randomized evidence. The problem about randomized trials, obviously, particularly, is people agreeing, are the people who agree to do trials actually generalizable in terms of the people who you want to treat with knowledge that you gain from those trials? So that's the big problem. But it's quite interesting over the years how we've managed to, I think, show that even though the population might seem not to be generalizable, in fact, you often do get reasonably generalizable results from trials. So it's really sort of, they are method for a quantitative paradigm. It's the strongest evidence, I think, because you get round confounding by indication in a more robust way than you can do with an observational.
So you've been a pioneer on research methods like trials. You've done incredibly influential research, particularly trials. But then in 2013, you took a big managerial role by going off to be the director of one of the main UK research funding programs. And I have to say, at the time, I was surprised that you would do that, because I thought you loved doing research and this is going to take a lot of your time away. Do you want to just explain that?
Really enjoyed it. I enjoyed bringing a sort of pragmatic GP perspective to funding decisions. And also, I enjoyed funding panels are often a bit black and white, as opposed to my approach as a panel chair and then subsequently as the funding board director. Was, this is a great idea. There might be some problems. Why not let's work with the applicants about this and see if we can get something that we all think is good and worthwhile. So I enjoyed the creativity, potential creativity of being on a funding panel. I was then asked to apply for the director of this funding board, and I thought, I'm not a natural administrator, but strategically I can have good ideas and I can be involved in creative decisions about how to support good pragmatic research. And so I thought, actually, this is an opportunity to do some good. if I don't like it, I can always resign. I'll see how it goes for a year or so. I'll give it at least a year or so, and see how we go. So, but I thoroughly enjoyed it actually, and I didn't have to. I wasn't the administrator. I was involved in strategic decisions about how things ran, and obviously I was involved in some of the administrative stuff, but very little really. It was mainly strategy, being on the panels, deciding which way we should be going, and trying to fund good research. And I really enjoyed that, and it's very interesting. So the problem for me then was that I was working 6+ days a week. So I then had to, I think, make what was a difficult decision for me to give up clinical practice at that stage, because I didn't want to give up completely teaching. I didn't want to give up research. And I thought, and it turned out to be true, that so long as I was in very close contact with clinical colleagues, I wouldn't get distance. I would still understand what the clinical context was. And I always think about it as a clinician in my studies and in applying for grants. I'm still a clinician, it hasn't altered my perspective at all.
What you've just said about the 6+2 days thing leads me to what I've been dying to ask you, which is, how do you do it? You've published over 500 papers. Looking at your website, I thought you were cutting down, but you seem to have about 4 major research programs still on the go. It's easy to get a flip answer from you about how you do it, but seriously, what advice would you give somebody who wants to be equally productive? How can you do it? What tips have you got?
Trust the people that you who are running the project. Secondly, I would say, you want your team to be keen and to enjoy work, and sort of make research as fun as you can. I mean, obviously, universities aren't terribly fun places in terms of their bureaucracy, but make it fun. So I think most of my management meetings have been sort of fairly light touch, and I try and take a caring and generous approach to the people who work on my studies. If they need time off, whatever reason, they can have time off. I don't micromanage their time. I don't micromanage the studies, and all of that, you get that back in spades. Anytime you are generous to, or try and be generous to other people, you always get that back. Not that that's a reason for doing it, but it turns out to be true. So I think I've liberated myself from being able to spend lots of time managing projects that otherwise I wouldn't be able to have delivered the number of projects I have been able to, or lucky enough to do.
Is that difficult?
So I think those are really big things. I think I've had a trouble saying no to good ideas. So if people come along, or great people come along, I try and encourage them and encourage the idea, because we're about ideas and trying to convert those ideas to something that might make a difference to patients. So that's partly how I've ended up doing such a lot. And the other thing is, I probably haven't been as sensible as I should have been about balancing my work and home life. More a bit better at it lately, but certainly in the early years, I didn't come home early enough, and that was a mistake. So I probably would have ended up doing very similar amounts of things, but I think I didn't get the balance right, so particularly early on.
You've won so many awards, fellow of the Academy of Medical Sciences, and the Maurice Wood Award from NACRAG, and the Discovery Award from the Royal College of GPs, which are both for outstanding lifetime contribution. And then, of course, you're Commander of the British Empire from the Queen, CBE. But what do you do when you're not working?
What do I do when I'm not working? Well, I like films, and I think I love both. The streaming services. I think they provide some really interesting variety of stuff. I love walking, just getting out, being under the sky, near trees. I found very, very therapeutic. I keep the music going as much as I can. So that's something that went a little bit, I think. If you don't have time to practice, your skills do go down a bit. So I'm practicing. I'm getting the cello out a bit more now, which is great. My wife and I are now in a local chamber orchestra, which is great fun. Joined a choir recently because my wife Alison dragged me along, and I think it's very therapeutic, very nice thing to be involved in singing. So music's very prominent. And I think physical activity for me, I'm a very bad tennis and badminton player, but I play a few times a week.
Whenever I've met you at conferences, you've usually be on your way back from a run.
Yeah, I sort of I jog and walk. I don't know what that's called these days, but anyway.
Looking back, we've talked a bit about your career. Is there anything you do differently if you were starting your career again now?
It's difficult to say because so much of a career is a little bit of serendipity, something about life choices, and they all meld together. So my journey to being involved in research, I wish I'd joined a good unit early on, rather than wasting. It wasn't really a waste of time because I learned actually what bad research is, and that's probably helpful. Um, so I think be involved with a good mentor and a good unit as early as you can possibly be and get research training. So that was a bit of, if you could call it wasted time. I think that was a bit of a waste of time. I think doing work at home was something I discovered, I think only in the petrol crisis. I had to bring work at home. And that was actually a jolly good thing. I was trying to completely separate work and home. And I don't think that's helpful for home life. And it's not sure it's helpful for work life either. So being able to be flexible uh, and finding a career path that is flexible. And I think being a clinical academic is brilliant, particularly in general practice, just so flexible. Make sure that as early as you can develop, good work-life balance. And I think I would have done that differently if I had my time again. I mean, it wasn't bad, but it wasn't good. I
I
think
suspect that, sorry.
no, I was going to say my poor wife had to look after young children for too long in the day. That wasn't really necessary, and it wasn't kind, I think.
I suspect almost all successful academics would say the same thing, that looking back, they should have done their work-life balance a bit differently. But
Yeah, maybe.
easy to say. Paul, it's a great pleasure to talk to you and to find out a bit more about your story. Thank you very much for doing this. Thank you.
Delighted. Thank you, Chris.